Hi, my name is Diane Bada. I'm a licensed clinical social worker, and in this video, I'm going to talk a little bit about some of the symptom overlap between bipolar disorder and post-traumatic stress disorder, and why, unfortunately, many people who actually are suffering from trauma or possibly post-traumatic stress disorder can get misdiagnosed with bipolar disorder, and some of the kind of complications and frustrations that can emerge from that. This is something that has come up in conversations with colleagues, with friends, other healthcare providers, just as like a trend that we've kind of noticed. And it's something that can really create a lot of problems for patients down the line. So it's something that I wanted to cover. Also something that some people had expressed some interest in wanting some more information on. I'm going to go over some case studies, the difference in definition between PTSD and bipolar disorder, and the difference in the diagnostic criteria, and then some things that could be helpful just for mitigating this problem moving forward. So let's get started. Major thing that can be difficult when it comes to mental health diagnoses, just mental health treatment in general, is that the symptoms are not visible, right? So much is therefore kind of subjective. A lot depends on how patients report things. It's not like diagnosing a broken bone. You can't see it, right? You can't just do a scan. And this is something that just makes the field of mental health a little bit tricky in general. What is significant and what stands out in terms of treating PTSD versus bipolar disorder is that bipolar disorder is an organic condition, meaning it derives from something in a person's brain chemistry that leads to these highs and lows. Post-traumatic stress disorder does not. And so if somebody has PTSD and is taking medication for bipolar disorder, not only is this an ineffective treatment, but you're potentially doing this person a disservice because you're putting them on medication that they don't need. Unfortunately, this happens a lot. More specifically, to get a little bit clearer just about the difference in definition, so post-traumatic stress disorder, PTSD, and again, if you've watched some other videos, this is a term that is a little bit overused. It's a little bit overdiagnosed, especially in the age of TikTok, but true PTSD is something that derives from witnessing or experiencing a traumatic event: war, famine, an assault, major accident, severe abuse, things like that. And to meet criteria for PTSD, you really need to see a lot of intrusive symptoms. What does this mean? So nightmares, waking up in the middle of the night, re-experiencing something. Kind of a characteristic feature of PTSD is looking to avoid things that remind you of the event. So not wanting to go a certain place if it reminds you of an assault that happened. You'll also see something called hyperarousal. Usually a person is very kind of on edge. They might be not able to sleep, more reactive. Generally, these symptoms persist for a significant period of time. Bipolar disorder, on the other hand, it can have symptoms that can look like this. So with bipolar disorder, again, this is a condition that relates to a person's brain chemistry. You see very high highs and very low lows. In order to truly diagnose bipolar disorder, a person needs to have experienced at least one manic episode. A manic episode is when a person kind of almost loses touch with reality. It's not quite psychosis, but it can look like that. But they have so much energy, they're not sleeping for days, they have all of these ideas, they want to start 12 new businesses, they buy a new house, they buy a new car, just a lot of energy. They feel on top of the world, they feel euphoric. I live in New York City. I was born and raised in New York City. A perfect example of a manic episode. Years ago, I saw somebody in the subway, one of the subways, Union Square, singing karaoke, wearing like minimal clothing at like 12 p.m. on a Tuesday. That is kind of textbook what you would see in a manic episode. Just wild, extreme euphoric behavior. Generally, this results in hospitalization because people aren't sleeping, they're not eating, and they're acting in a way that is kind of crazy. You don't see that in PTSD, and that's very, very important to understand. Bipolar disorder, when the mania ends, a person will then often crash and they will fall into a deep, deep depression and often regret things that they did, things that they said, how they behaved during a manic episode. And so bipolar disorder, if it's untreated, can really be heartbreaking, and it can cause a heck of a lot of damage to a person's life. People lose jobs, people lose relationships. Untreated mania can really be so destructive. But in order to really truly get that diagnosis, you need to have had a manic episode. And I can't tell you how many people I've encountered who have been diagnosed as bipolar and have not experienced a manic episode. So clearly something is being missed there, or the diagnosis is inaccurate. What else? What stands out in terms of kind of overlapping features? So unstable mood. So obviously bipolar disorder, there are severe ups and downs. In PTSD, people may also experience depression because depending on the nature of the trauma, a person might not know how to trust people. They might not want to go outside, so their actions are limited. Disturbed sleep is also something that you see a lot in both. For post-traumatic stress disorder, due to this hyperarousal, this hypervigilance, especially if an attack occurred at night, a person might not want to go to sleep, or their body may be so activated, for lack of a better word, that it's hard for them to sleep, or they'll struggle with insomnia, or they're waking up due to nightmares a lot. In bipolar disorder, manic episode can bring on not sleeping for days. And what is a key feature as well of bipolar disorder is that the person's not tired. So not only have you not slept for 3 days, but you feel great. That is something that is very, very much characteristic of a true manic episode. Okay, what are some factors that can kind of contribute to misdiagnosis? One is the symptom overlap. Another major factor that's really important is that sometimes trauma history isn't taken accurately, or individuals might not disclose something that is traumatic. I can't tell you how many times worked with somebody and during an initial intake appointment asked about trauma history, and they're like, no, nothing significant really stands out. And then 6 months later, I find out that there was something super, super significant that occurred that would be classified as traumatic. And if somebody is meeting with a patient 1 time, 2 times, oftentimes patients don't recognize their own trauma, or it isn't asked about. So it's just something that's kind of glossed over. So you can very easily miss PTSD diagnosis because of that. Another factor relates to poor training, or kind of a stigma or misunderstanding. The term bipolar is thrown around so much now in popular culture, and people get called moody, or people are told, oh, you're having mood swings, and it's very easy then for somebody who actually is exhibiting symptoms associated with post-traumatic stress disorder to be misdiagnosed as bipolar, especially by a clinician who is not experienced. Another factor can relate to burnout. Sometimes clinicians are overwhelmed and kind of exhausted, and they see somebody and they make a very quick, hasty diagnosis because they're really not taking care of themselves, and they're not super invested in providing quality care. And unfortunately, that does happen in the medical field. It's a reality. Okay, what are some potential kind of case studies? What are some scenarios where one might be diagnosed as the other, or a correct diagnosis might be missed? So one example could be a combat veteran who presents to, let's say, a psychiatrist with a history of mood swings, irritability, and insomnia. If a clinician is not careful about how they do their intake, with the questions that they ask, how many times they meet with this person, they might diagnose them as being bipolar and totally miss PTSD. If they don't know this person has a history of combat work, they could very easily miss it as well. What's another example? So somebody who experienced severe childhood abuse, let's say that they are having flashbacks, they're waking up in the middle of the night, they are very sensitive to certain triggers and kind of avoid certain places or certain people. They feel emotionally numb, and they don't want to talk about their past. I can't even tell you how many times people say, oh, I don't really remember my childhood. It's kind of spotty. That can be a major, major sign that somebody experienced some major trauma in childhood. That can be considered to be avoidance. But if a person is not talking about their trauma, can't really know that it's there. So in a situation like this, even though a person's having flashbacks, they're engaging in avoidance symptoms, 2 things that are very much associated with PTSD, this person might get misdiagnosed as having bipolar disorder instead. One more example, a person with a history of trauma, they seem to be kind of emotionally labile, their moods are very up and down, they're engaging in behavior that is quite impulsive. If a clinician is not skillful in terms of asking more about the patterns in these the shifts in mood, the patterns in impulsivity, they may not recognize that this is trauma related, that there is no mania there. And so they may get misdiagnosed as having bipolar disorder when in fact there is a significant trauma history. Okay, why is proper diagnosis important? So some people may be watching this and thinking like, well, like if you're getting help, does it really matter whether we call it this or we call it that? It does. And it does because accurate diagnosis leads to accurate treatment. PTSD and bipolar disorder have different causes. And as a result, the treatment is very different. Sometimes it can be treated with a medication in the short term to make a person's symptoms more manageable. So if somebody's not sleeping, you may give them a medication to help with that. If somebody's severely depressed, you may treat them with an antidepressant to help them engage more in therapy, to get out of bed, to engage more in everyday life, to reduce some of the intensity of the feelings that come up when they are in a situation that reminds them of the trauma. However, the main focus of treatment for post-traumatic stress disorder is going to be a trauma-focused therapy. The gold standard treatments include cognitive processing therapy and prolonged exposure. Prolonged exposure focuses on desensitizing a person to the things that they've been avoiding, basically getting them more comfortable facing the things that they have been wanting to run away from that are very arousing for them and make it hard for them to function. Cognitive processing therapy is basically a form of cognitive behavioral therapy that has been modified to treat PTSD, and that is more focused on addressing some of the thoughts and beliefs that can emerge about a person as well as other people, the world, etc., after a trauma. Bipolar disorder, on the other hand, therapy can be helpful, but the main treatment is going to be in terms of medication. So you see bipolar disorder treated with mood stabilizers, kind of as like a first-line treatment. Therapy can be great, especially if a person has a lot of shame regarding things that happened during a manic episode, or just some of the difficulties that they've encountered from having, untreated or undertreated bipolar disorder. But there's a clear distinction there. If you give somebody with PTSD mood stabilizers, you may see some changes, but is that the most effective form of treatment? Absolutely not, because at the core of PTSD is a lot of avoidance, a lot of numbing, and a lot of deeply rooted beliefs about how to go about the world or what's going to happen, whether or not people can be trusted, whether or not some people are fundamentally bad, etc. You see a lot of cognitions and beliefs like that emerging in PTSD. So therapy is really going to be the more effective thing in the long term. Lastly, accurate diagnosis is important for patient identity and their own empowerment. An inaccurate diagnosis can ruin somebody's trust in the medical system, in healthcare providers. I can't tell you how many stories I've heard of people, again, getting diagnosed as bipolar after a 10-minute visit, and they really feel unseen. They feel skeptical. They might totally write off psychiatry or therapy as a whole and not return, which can lead to so many people not getting helped because the right treatment will yield results if it's done properly. So that's another important thing to take into account as well. Okay, what are some strategies for avoiding misdiagnosis? So one includes really doing a comprehensive assessment, taking the time to ask the right questions, to ask about trauma history, to provide screeners. There are specific screeners that clinicians can use to more accurately assess for whether or not a person has had certain traumas in the past, things that came up in their childhood. Unfortunately, not all clinicians have the time for this, and due to some changes in terms of how things are structured, especially in certain countries, it leads to less time, and so there's a lot of pressure to just see people quickly and get them in and out, and unfortunately that can lead to misdiagnosis. Having a multidisciplinary team is also something that can be really helpful. So having both a therapist and a psychiatrist interview a patient can be great, because many times patients may feel more comfortable disclosing one aspect of their past to one provider and more comfortable disclosing other information to a different provider. That's just the reality. It would be great if everybody provided the exact same information to every clinician they encounter, but it just doesn't work that way. So that is something that's important. When meeting with a psychiatrist, a patient may not want to open up so much about some emotional things. They may want to stick to the facts, medication or specific symptoms. And if they meet with a therapist, they may feel more comfortable talking about, oh, hey, this really tough thing happened to me as a kid. Many times it's It's hard to predict, the why or the when or the how. It just relates to kind of the rapport that's established, but that's certainly a factor. Training, making sure that clinicians are trained in differential diagnoses, that they are encouraged to really think critically about a symptom profile or a cluster of symptoms is hugely important for preventing misdiagnosis and encouraging better diagnoses. And lastly, all care to really be trauma informed. And even if somebody doesn't think that there's a trauma history, just asking the questions anyway, giving somebody a screener just in case, because you'd be so surprised by how many times you might not think somebody really has gone through something that could be causing the symptoms that they're having, and they actually have. So those are some helpful things for kind of improving the quality of care and improving diagnostic validity. Well, I hope that this video was helpful. I hope that it answered some questions that you might have about how post-traumatic stress disorder is different from bipolar disorder and why they can often be misdiagnosed. I will be uploading a new video pretty much once every week, and am looking out for specific topics that people might want me to cover. So if there's something that came up as you're watching this, a question that you have or a topic that you want to see discussed, feel free to comment. Please like and subscribe. This is kind of a new channel, but something that I'm really passionate about. I think psychoeducation is so important, especially when it relates to mental health. So if you enjoyed this, please do like and subscribe, share, and yeah, I look forward to having a new video for you soon. Take care.